and officially welcome everyone to this really exciting presentation that we're going to have from Dr. Raymond Zakhari. I am Dr. Kathy Collins-Fillet, and I'm very proud to introduce Dr. Zakhari, who is triple board certified nurse practitioner trained in sex therapy, along with many other specialties. He's on the staff at New York Presbyterian Hospital and founded Metro Medical Direct, a medical, psychiatric, and telehealth house calls practice in New York City. He was published in peer-reviewed journals, has presented on various topics at the national level also. He's also the host of the podcast called The Psychology of It All, in which he explains the self-sabotaging habits of the mind that drive our behavior. I'm sure none of us do that. He was deployed to Iraq in 2006 from the Air Force. Recently, he has finished writing the Psychiatric-Mental Health Nurse Practitioner Board's review book and expects that to be published by Springer Publications in March of 2020. So welcome, Dr. Zakhari. We're very excited to hear your presentation and hopefully have some time for a discussion at the end. Carolyn, would you mind turning your camera off? Thank you.
Thank you so much for having me. Thank you, everybody. So you've heard a little bit about my bio. What I'm going to talk to you tonight about is called Engaged Patients to Improve Quality, essentially. And the reason I'm going to do this is because a lot of you, I understand, are in a DNP program, and many of you are family or psychiatric nurse practitioners already or training to become the other. And some of you, I understand, are midwives as well, which tends to encompass some primary care in the women's health domain. And so I think this is an important topic because there's a lot of push around patient engagement, and there's also a lot of push around outcome quality measures. So if there's a way to combine the two, I think that's a worthwhile endeavor. So one of the things I'm going to talk about tonight, can someone mute that? I think that's Lydia. If you can please mute because you're coming across. So what I'm going to talk to you about is how to engage the patient in an episode of care using the Bathe technique, which is commonly used for psychosocial interventions in the primary care setting. But this same model can be applied to help you generate and clarify your topic of concern when you're coming up with a quality improvement project. And it can also help you clarify the concept for consideration, because one of the problems you'll notice is if the questions are not exactly clear, your measurement may not work out and your intervention will also become derailed. And so that can derail an entire project, but also the outcome is less meaningful if we're not being precise in what we're talking about. And then in therapy, we do this thing called the miracle question, but it's an interesting thing to apply to the various stakeholders that are potentially interested in or not interested in your quality improvement project. And then I'm going to talk to you a little bit about my own QI project that I did for my doctorate, which was sort of born out of similar strategies in order to get buy-in along the way. We can also take questions. If you want to just put them in the text box, you can do that so you don't forget them, or we can take them at the end, whatever's most convenient for you. So let me just give you some caveats to keep in mind whenever you're thinking about quality improvement. First caveat is you have to realize that something is incentivizing the status quo. There is a reason that what is going on is continuing to go on. There is a perpetuating factor to the current situation, and it's important to figure out what that is. Another thing to keep in mind is when figuring out what that incentive is ask yourself, what does the status quo allow or what does it prevent? And that's a good way to help you flesh out who the stakeholders are and what are the potential facilitators and barriers that you will have to contend with. And then the other question is you have to ask yourself, so what's the harm in the status quo? I mean, if it's simply just not evidence-based, but there's no real harm, what's the problem? And that's even more applicable in things like psychiatry and mental health. And the reason I say that is, you know, we do evidence-based practice, but as we get to the next slide, I will show you that not all evidence is created equal. There's a lot that's done by way of anecdote. There's a lot that's done just merely based on tradition because someone has found in their experience it seems to work. The other problem we have in issues of mental health care, there are way too many variables that remain unaccounted for with the current evidence. For example, we don't necessarily pick people with multiple comorbidities, with poor access to medication, with various history of adverse effects on polysubstance to enroll them in our clinical trials. So when we say evidence-based, realize, of course, sometimes that's merely aspirational, and not all evidence is created equal. The other thing I want you to think about using the Bathe technique, which I will flesh out as we go on, and the miracle question, is to really create a language to clearly define the problem and define what those expectations are going to be. In other words, how are you going to know if this problem is solved? How are you going to know that you've sufficiently addressed it? And it can't merely be the fact that people are doing something differently, because the outcome really matters. If you're doing something differently and the outcome is not desirable or even not tolerable, even though it may be desirable, it may not be tolerable to the stakeholders, then that's going to be a problem. So having a way to have that discussion, if even in your own mind or among your peers or with the various stakeholders, is going to be really important. And the other thing to keep in mind is as you go through the algorithm of the Bathe technique and the miracle question, you're going to want to figure out how to measure and quantify. So what does all the improvement actually mean? What is the numerical clinical significance of it? Because that's how you're going to translate the worthwhile nature of the intervention to the people that you're expecting to fund the intervention, if not in the short term, at least in the long term. Because at the end of the day, nobody's going to work for free, and we're going to have to figure out how are we going to justify the associated cost with what we are proposing. Some other questions you're going to have to answer along the way is what will happen or what will no longer happen pending your intervention? And then what are you going to do to sustain it? Because suppose you graduate or you move on or you change jobs, how do you intend to keep that evidence-based practice change sustainable? And, also issues of cost are considered as well in terms of sustainability. I mean, someone may say, here's some money to do it in the short term, but good luck to you in the long term. And oftentimes finance can be the impedance in maintaining change. So let me tell you a little bit about the Bathe technique. Bathe technique stands for background, affecting, troubling, helped, and empathy. So in the traditional clinical setting, about 60% of what comes in is psychosocial based in primary care. So in primary care, you'll have someone come in and say, I have back pain, or I have this unrelenting ache, or I can't sleep. And so you want to figure out in your 15-minute hour, if you will, how can you quantify this problem? So for example, well, what's the background? What's been going on in your life that's been leading up to this, essentially? And so that's the primary care approach. In the quality improvement perspective, the background information is all patients who got a head injury. This is my own work. Well, anyone that bumped their head in the hospital essentially would get a CAT scan. And this was going on pervasively for as long as I've been here, at least 12 years, and even before me, because I used to work here prior to. But everyone that bumped their head would basically get a CAT scan. Anyone that bumped their head in the community would come to the hospital and demand a CAT scan. And the problem with that is this was not exactly evidence-based work. This is essentially eminence-based work. The reason we do this is because Dr. So-and-so says to do it, or this is what we've always done, or so there was no good rationale. And then it further got complicated when you went to look and see, well, not only is this not evidence-based to CAT scan everyone that bumps their head, but the evidence is in the opposite direction. And that is to say, we're saying you should not be scanning people that bump their head unnecessarily. In fact, the exposure to radiation, depending on their age, is considered to be more harmful down the road. So not only are we sufficiently not doing harm, we're actively doing harm, but this is a precedent that has been set. When I first tried to roll out this project and I took it to different areas and such, people would insist that surely there's a policy that says everyone that bumps their head needs a CAT scan. I'd say, well, okay, find the policy, I'll wait, and no one could find it. So there's a lot of cultural inertia into the background of the problem. The next part of the A, the affecting. So if you're in your symptoms, when you're doing this in a primary care setting, say, well, what of these things that you have mentioned, because you've got 15 minutes, you don't have time for the litany of associations. Well, I can't sleep and my back hurts and I'm not eating well and I've gained weight. And okay, we can only address really one problem in this visit. So how are all these things affecting you the most? Well, you could say the back pain keeps you from sleeping, and the sleeping makes you tired during the day, and so you don't have the energy to do the exercises, and so that's the problem, right? So that's how it's affecting, at least in a primary care setting. In this quality improvement setting, you can say, well, how is this unnecessary use of CAT scanning affecting the patients, the institution, the insurance company, whoever the various vested interest stakeholders are? So who it's affecting are patients are being unnecessarily exposed to radiation. It's affecting workflow because now you need to order the test and transport to the test and read the test and follow up and deal with the incidental findings. And of course, all of that yields to increased cost. So that's who it's affecting, at least from patient. It's affecting them in terms of workflow. And then the other side is, so what do we do with the information? Well, oftentimes you wind up getting low yield. So in the case of the CAT scans, over 90% of the scans were negative, and the other 5% showed incidental findings that no surgical intervention was going to be done. So now you have, this small percentage of the population that's had all of these scans with all of this money and all of this exposure, and they're really low yield. So what? This is how we do it. Everyone's used to it. Everyone likes it. What's the problem? People are used to low yield. I don't want to be in that 5%, right? There are a lot of reasons where you can drum up this reason to scan, maintain the status quo, if you will. So then what you do is you can ask the person, what is troubling? And so of all the symptoms you're having, so what of this troubles you the most? And this is really where you're drilling down to the person or to the institution or to the setting to figure out, well, what is the one problem that we need to address for you today? What fear might that be? In the case of the back pain patient in primary care, you might say things like, well, is it the pain that we need to address, or is it the sleep we need to address, or what exactly do you think we need to, what's bothering them? Say, the pain's really not that bad. I can ignore it if I could just sleep through the night. So maybe your issue is going to be around dealing with the sleep and not so much the pain. And maybe the pain is psychosocial, but you haven't really figured that out. It's not back strain. Maybe they're just in pain because they're not distracted, or their sleep hygiene is poor, or there's 100 reasons that you need to drill in. But what you're trying to figure out is what symptom is most troubling. So when dealing with the institution and the healthcare providers around this excessive use of CAT scanning, the biggest fear they had was, well, what if I miss something? That's a big fear. It's legitimate. Another one is, when you talk to the nurses, some of them will say, well, we did something wrong. The patient fell on our watch, and so we're going to give them a CAT scan as if that's like making amends. I think they'd rather a box of chocolates or some flowers rather than a CAT scan, especially when you try to explain that a head CT scan is on the order of about 400 x-rays. And those 400 x-rays really are not going to yield anything. I mean, if someone said to you, you have a chest cold and a cough that's persisting, but in order to diagnose it, I need to do 400 chest x-rays all at once. I mean, how many people would sign up for that? Very few. But essentially, if you communicate it in a way that is understandable to the patient, that oftentimes will garner buy-in. Now, this obviously takes time. It's easy to click a box and say non-contrast CT of the head, and they get rolled away, and you see a negative test, and you say, okay, here's your discharge instructions, and away you go, right? So there's a perceived ease to the workflow, click and transport and done. So what you're going to do is now you're going to ask, so by addressing the troubling portion of what is perpetuating the status quo, this helps highlight for you the barriers that you may need to overcome when you plan an intervention. So I targeted my intervention towards allaying the fears of the providers by presenting them with the evidence and giving them some multiple choice questions where they could practice not ordering a CAT scan in a simulated environment. And I also presented them with the research that shows, this tool that you could use has 100% sensitivity in picking up all clinically important brain injuries. So what are you saying? I'm not saying don't scan. I'm not saying abdicate all responsibility. What I am saying is scan prudently. So it's important how you phrase. You don't want to be labeled the non-this person or the non-interventionalist or that's so-and-so's patient. They don't scan anybody. What you're trying to do is highlight to them what would be a better alternative practice and allow them more options. So I would highlight to them, say, there is this evidence-based clinical decision tool. Someone wrote it up in the comments called the Canadian CT head rule. Number one, it's in the public domain, so you don't have to pay to use it. Number two, it's readily available. And it has this 100% sensitivity in picking up all clinically important brain injuries, assuming it's applied to the population of ages 16 to 64. Okay, good. So in the patient that's 16 to 64 years old that bumps their head, if they score in on any of the criteria, now you have a reasonable index of suspicion to justify scanning. So now you can scan and say, because they have these findings that consist with a head injury, you've raised the yield, you've raised the likelihood of actually finding something with the scan rather than blanketly scanning people across the board. So that's kind of helpful. And they were like, okay, I could go along with this. And what about my documentation? Because I don't want to get sued. And I want to make sure I saw the patient. And I want to fulfill all my obligations regarding what I'm supposed to do. Fine. You turn it into a template. They can click it. It fills out the body of their note. Their assessment is done. And why this is also helpful is, you know, interestingly enough, the evidence doesn't say when to scan. There are some traditions out there. Some say scan immediately. Some say wait 4 hours because the bleed is so small you might not catch it in time. And then you've got people that say, well, I scanned and it was negative, but now they're having symptoms, so I have to scan again. And now you've given them 2 CAT scans. The reason I dreamt up this idea is because I had a patient in psychiatry that came as a trauma. So she started her admission to the hospital with a CAT scan of the head, sinus, and C-spine. So she started her admission with 3 CAT scans. She slipped in a puddle of water, bumps her head overnight, got a 4th CAT scan in a week. Great. Next week, slipped again, bumped her head. We got a CAT scan, got a CAT scan again. This woman had 5 CAT scans in 2 weeks. That's almost 1,000, 1,500 x-rays. That's the level of radiation we're talking about here. So now what do you do? Well, so then I said, there's got to be a better way because we're not going to scan this woman every time she bumps her head. There ought to be a better way. So that's what gave birth to developing the this clinical decision tool for CAT scans. So now we've identified the fears and what it is we're exactly trying to target, how we're going to allay them, how we're going to facilitate and contend with our barriers. That's the most troubling symptom. That's what's going to help you overcome the cultural inertia, which is entrenched in many places. Now you want to ask with the patient, say, well, what has helped you in the past when you've had trouble sleeping, if we're talking primary care? What has allayed your fears? And this is where you're doing the patient engagement. And the patient engagement essentially is you are talking to the patient and leveling with them and saying, look, I'm sorry you fell down and bumped your head. We will watch you very carefully. Here's what we can do. Have you ever bumped your head before? How did that go? Have you ever had a CAT scan before? What is your concern about that? We believe CAT scans to be this level of usefulness. This is what we're really talking about. And so what happens is now you've done this coming alongside the patient. They're engaged in their care. They've gotten the face time, which oftentimes is what people really want. People want to feel heard and validated. So you're giving them the face time, especially around an event, and you're going to follow up on them. And maybe you'll give them a checklist that says, if you notice any of these symptoms, please report to your nurse, or we will assess you for these same symptoms going forward. By the way, this tool was developed to send people home, essentially, not keep them in the hospital. So I said, well, how much more in the hospital when these people are followed by nurses and everyone's seeing them every day and multiple times a shift? Why wouldn't we use this tool in-house? The way this study was initially done was they'd send people home and call them in 24 hours. So if we're sitting in the hospital watching you, why would we not use this here? So that's what has helped the most, and you're capitalizing and coming alongside the patient. You're also conveying to the patient, look, we claim to be an evidence-based practicing institution. We're going to do things according to the evidence. So we say, right, we're all about the evidence-based care. Well, the evidence does not support this test that we're about to do for you. You still want it, right? That's kind of where we're at. So we're acknowledging the limitations of the evidence. And then finally, when you do the empathy, which is obviously pervasive, but make a concerted effort to express empathy for the patient, when you're asking them what has helped before, they say, oh, well, I do this bedtime ritual and that really helps me sleep. Great, well done. And what you're doing is you're taking a strengths-based approach to helping the patient essentially address their own concerns. Well, when you take the empathic approach to a systemic level, what you're doing is you are validating the concern of, say, the resident on call. You're acknowledging that nurses feel that change is hard and we feel like we're letting them down if we don't send them for CAT scan. You're acknowledging how what we're going to do is going to trouble the thing that you are most afraid of. So for example, you're afraid of missing something. Well, now this tool allows us to be more specific and prudent in the use of technology. And so you're really coming alongside, you're capitalizing on strengths, and you're expressing to them how you're going to try to contend with their hesitation to this proposed new thing. It doesn't even have to be monumental, but there's clearly a proposed new thing that they're not used to. And change is generally not well received. It takes some time to get used to. So you validate the concerns, and then you acknowledge change is hard, tell them what you're going to do instead. And you're doing this very specifically to each person in the care cycle. That includes the patient, maybe the resident, maybe the nurse, maybe the administrator, maybe the consulting service. I mean, you're doing this for the people that need it, but you're really coming alongside, because in the process of fleshing out the problem, you're getting buy-in, you're peppering. There's some education that's going on. You're causing them to be reflective as to why do we do things this way, you know. So who did I do this on? I did a population study, 18 to 64-year-olds that were admitted to the hospital who had sustained a minor head injury. And usually in the hospital, that means they have fallen and they bump their head. And if they do that, you know, the tradition is that we give them a CAT scan. And so then what did we do? What I was looking for, what would be the outcome that I could measure, is what is the likelihood of adopting this tool into your clinical practice? So I was not outright going to derail the CAT scan. I was more looking at their attitude and likelihood of adoption. And if their likelihood of adoption were high, then you could see if likelihood translated into actual adoption, because you could then see your CT scan rate. An indirect measure, and they didn't feel like they were being so constrained and being told what to do. The comparison to my group was going to be a comparison to treatment as usual / natural experiment. So as the residents rotated, if they didn't get the in-service, they operated under clinical inertia, or, and so they would just do what they thought they ought to do, which is scan everybody. And those that got the in-service, they would, ideally apply the tool if they had a high likelihood of adoption. And the outcome was the rate in CT scans for minor head injuries. And minor head injury was defined according to the Glasgow Coma scale. They had to have no deficits on that scale. And that's how you could tell, which is interesting because a lot of people don't exactly, they know how to define major from minor head injury in the meta sense. But if you were to really nail it down and say specifically, how do you know minor from major? What criteria do you use? That's not exactly at the tip of their tongue. That's something they're probably going to Google. So when you give them a tool, they're like, oh, okay, this is what you mean by minor. And so that in and of itself is very enlightening, also allays a lot of fears. And the other measure was increase in knowledge. In other words, knowledge of the evidence. The evidence does not support scanning everybody for minor head injury. And then I did it over the span of 90 days, just because semester was ending and I wanted to catch enough times. And the article did get published in the Journal of the American Academy of Nurse Practitioners. If you're interested, you could look at it right here. So now what do I do with these people? Well, so the thing got adopted. The CAT scan rate went down significantly. I did this work probably 5 years ago. The numbers are not exactly the important part. It went down by the expected benchmark. I think it was around 30 or 40% decline in CT scans. And the information provided had to be targeted toward the various stakeholders. What's interesting is you want to capitalize on financial incentives. So much of healthcare is paid for and is capitated based on the diagnosis, and all of this is bundled in there. But in acute care teaching hospitals, this is not really focused on. It just seems like care is free, essentially. You come in, no one has any regard. If I look around at every scan and test and, I'm going to sit at this computer, and I've seen people Can easily burn $500,000 in 4 hours on 2 patients. I mean, easily, between the MRI and a blood test that's fancy and, 10 consults and whatever, you could easily blow through a lot of money very quickly. So what happens now is the information provided is very much targeted toward the stakeholders. So to the administrator, you're going to talk to them about workflow and, not needing to hire more people for all these transports that need to go on. For the patient, you target the information in terms of prudent scanning. For the provider, you're helping them understand that there's a tool that they're not going to miss something, and here's their documentation. And so you're basically targeting everything toward the individual. And capitalizing on financial incentives. Well, I used to work for an insurance company many years ago, and one of the things I would have to do would be to review the justification for a hospitalization if the patient came from a skilled nursing facility. And the reason that was important is skilled nursing facilities can do some things like IV hydration, antibiotics, they can get some portable testing, stuff like that. So the question is, if you sent the person to the hospital for something that the facility could do, generally that admission would be denied unless something big was discovered and then you could facilitate it. So when I looked at that, you realize, of course, that in the primary care world, the concept of prior authorization is occupies a lot of time in a traditional insurance practice. So it's interesting, and I wouldn't be surprised to see if down the road, where you may not have prior authorization, but one of the regulators, maybe CMS or some third-party payer that's a large payer in a particular system, may request essentially the questions of a formalized clinical decision support tool like the Canadian CT head rule as to justify doing the CAT scan. And if it's not there, then there may be a financial ding or a non-reimbursement for something like that. The other thing to look at is everyone is concerned with patient satisfaction. So enhancing patient engagement and enhancing throughput and reducing wait times are known factors that enhance patient satisfaction. So if we're not forever shipping you off to test after test, delaying your discharge, keeping you waiting, those things are known to be patient satisfiers and less work, essentially. It's interesting. It's a little bit less work in the meta sense, but it's more work in that you have someone, the provider right at the bedside, has to come alongside the patient and spend some time with them in the moment, rather than clicking a button, scanning, and repeating that process for them. So that's all I have on the Bathe technique. Now, the miracle question, I guess I didn't put the slide in here. I thought I did, but the miracle question, let me just tell you about that. So the miracle question is, if you were to wake up tomorrow and your presenting problem would be gone, how would you know? How would I know that you no longer are afflicted with this condition? And the question is, that's a very helpful question to clarify an expectation of care. In other words, how are you going to know the problem is solved? It's not just a decrease in, say, CAT scans, because you want good outcomes still. So like, suppose we do 0 CAT scans, but people are comatose on the floor. That's a problem, right? That's not a good outcome. So the question you want to ask is, how would you know if the problem were solved? And what that does to a person right up front is it helps identify what is the expectation of this care episode and what is the expectation of the outcome of this project. Well, I will know that you've sufficiently addressed this if the rate of CT scans comes down by 30 or 40%, usually a benchmark is identified in the literature, and my outcomes are comparable or better. That's how I'll know that this particular intervention was a success, or you've sufficiently dealt with the problem, or cost of care has gone down, or patient stat scores have gone up, or whatever. But clarifying that expectation up front is very much a helpful step, because there's nothing like getting to the end of the experience and realizing, oh, that was it. I was really expecting this, but no one took the time to clarify that in the process of planning this sort of implementation. So I hope you found this enjoyable. This is some ways that you can be in touch with me after the fact. Hopefully some of you will be going to the American Academy of Nurse Practitioners in New Orleans in June. If you are, come by, say hello. We'd love to talk to you then. And if you have any questions, I'll be happy to take them now.
Thank you so much, Dr. Zakhari. That was fabulous. There's a couple of questions that are popping up in the chat box there. I don't know. Can you see the chat box?
Let me just scroll up here because let me just scroll to the top.
There's Stephanie Patterson, I guess. Could you provide an example of how you have used the Bathe method with your psych patients? I happen to be a family psych nurse practitioner.
Yeah, so I used Bathe primarily when I was in family practice. So when you have a patient that comes in and says, you know, the most common complaint is I can't sleep or I can't concentrate, right? Or I'm just really anxious. So you'll ask, so what's been going on? And they'll say, you know, well, I have a new job, or I have a big test, or I was just fired, or they'll give you some of the story leading up to the situation. And what you're trying to do is figure out, well, of all these things going on in your life, how is this affecting you? So what, you quit your job? So what, the you know, financial problems are arising? How is all this affecting you? Some people are amazingly resilient, and they have this notion of, I can do anything no matter come what may. And it's not really affecting them. I sleep fine, I work out, I go to school, and hope for the best the next day. Other people, well, how's this affected? Well, it really keeps me up at night. Okay. And what else? Well, and I'm very distractible, and I'm just irritable with my family, and you know, it's hard to concentrate. And essentially, they're giving you the indicators of some condition, right? I don't know if you've heard of SIGI caps, but it's a mnemonic to hit the major diagnostic criteria of depression. So they're giving you the things that are what the impairment is in their daily life. It's interesting. Psychiatry, there's not a lot of cure. There's just not a lot of cure in psychiatry. Much of psychiatry is basically symptom management. So, you know, my pill is not going to change the circumstances of your life. So what I'm trying to do is enhance your own resilience, build up your coping strategies, maybe reduce the intensity of your feelings in the meantime. So what of all these things, how they're affecting you, what's troubling you the most? Well, if I could get one good night's sleep, or if I could just sit down to a meal without feeling nauseous, then I will feel better. Okay, well, let's work on that. And so in psychiatry, you know, all we're doing is treating symptoms. We're not curing anything here. So you may then help select either psychopharmacology or a behavioral intervention, or preferably both, to target that one specific symptom. And the reason you want to do that is you want to figure out, did this work? How will I know if it's working? And you don't want to be starting with 3 pills at once when one might suffice. In other words, consolidating the sleep may be the one thing that helps them build the resilience. They're less irritable. They may eat better. They'll feel more energy. You don't know, but it's helpful if you find the one troubling symptom that is the one thing that may give you the biggest bang for the buck. The other thing you want to do is really take a strengths-based approach. What has helped you in the past? And they'll hopefully be able to give you some things of how they've overcome some sort of burden or some sort of adversity in the past, or something they've survived. And you're going to say, good on you. And how did you do it? Well, I talked to my friend, I went to bed, or I said no, or I watched a funny movie, right? You know, you'll find out what their coping strategies are, and you want to encourage that rather than get them overly reliant on either a medication or a person. You don't want them trading one problem for another problem. So Bathe kind of works that well. It was initially designed for psychosocial interventions in the primary care practice. If you're looking for a book on that, there's a book called The 15-Minute Hour. It's a good read. It's got some practical applications.
Thank you. There's another question. It's a little bit off topic here, but I think people want to pick your brain, from Marley. As a psych mental health nurse practitioner, family nurse practitioner, please help me know how to acknowledge my paranoid clients' concerns without validating their delusions. And if you can link that to quality improvement while you're at it, please.
Yeah, great. So I guess the question becomes, what do you mean by validate the quality? I mean, so essentially, you know, there's a major tenet in cognitive behavioral therapy, which can be done in many settings and easily intervened. You know, there's a thing that says your thoughts and feelings are not facts, right? And so I generally say that, and I will draw them the triangle of how thoughts, feelings, and behaviors are all interrelated. So feelings can affect thoughts, thoughts can affect feelings, behaviors can affect thoughts, behaviors can affect feelings. And you draw this triangle for them. It's a CBT triad triangle. And you can help them see that while you may be, I mean, it's funny, we joke pejoratively in psychiatry, look, just because you're paranoid, it doesn't mean they're not out to get you. Both could be true. So essentially, you can help them. The goal is not so much to do away with the delusion or the paranoia, but because you might not be able to. And depending on the approach you take to this, be it if you're going to take a psychodynamic approach, like if you're going to be Freudian, you're going to say, interesting, you're paranoid. What does this paranoia prevent you from doing or allow you to do? That's one way. If you're going to take a strictly biological approach, you're going to say, oh, your dopamine is too much in this pathway or that pathway. I'm going to give you a pill for it. And, none of that's 100%. But taking a behavior, helping them realize that you can be paranoid, but you can also do other things. It's taking a yes and or a both approach to it, I find helpful. And sometimes if you can't move them beyond it, we're not going to be able to resolve this for now. Let's move on to something else. Let's do what we can do about what, find something we can do something about. How would you like to be helped today? There are no magic answers. In fact, they may just enjoy the process of being with you because you're the only one that doesn't look at them sideways, essentially. So that's not exactly probably the most satisfying answer, but allaying the fear, they say sometimes if you can help them identify reality and how do you know, to challenge the delusion, sometimes they say that's helpful, but I think that requires a degree of flexibility as well also. Everyone thinks they're the special case, but, someone's listening. How do you know? Well, I just think they're listening. Are your thoughts facts? No, your thoughts are not facts. But now, interestingly enough, between Siri and Alexa and Google Home, everyone is kind of correct. So now I've gone the other way and say, they are. You're right. They are listening. And they're listening to all of us. To tell you what we're going to do, we're going to flood them with data so they can't make sense of it. And we move on. I have a kid that I'm seeing now who believes, oh, what if they're listening at the door? Then they're going to know that people have problems just like everybody else. Let's move on. Is this helping? You're not listening? Is the paranoia helping? No, it's not. I try not to say don't do, but I will say things like maybe that's not so helpful to think about right now. And that tends to be helpful. And they can say, the other thing is you don't want to oppose them directly. You don't want to go from you're right. You want to get them to something like that's right. Yes, you may be paranoid, but that's not real helpful right now. Oh, that's true. It's not real helpful right now. What would be helpful? Let's do this instead.
Can you share a little bit of what you do in your podcast, The Psychology of It All?
Yeah, so The Psychology of It All initially started out as a self-serving enterprise. And by that, I mean, I would have patients that I would see and I'd find myself having to say the same thing over and over again. Oh, it sounds like you're catastrophizing. Oh, it sounds like you're denying all the positive things. Oh, it sounds like, and what we realized is essentially you are commenting on the defense mechanisms that were coming out, that were preventing movement in the therapeutic direction. And so in explaining the concept of defense mechanisms, I found myself having to do this a lot. So I basically recorded a podcast of all the defense mechanisms that they could play so that after the session, if I saw them, I would send them the link to my podcast, say, hey, listen to this. This will help you review the thing we just talked about. And so they would listen to that. And then it kind of progressed to the psychology of it all, then evolved into the behind the scenes of certain things. So one of the things I noticed that was quite popular was I should tell you, primarily in my practice, it consists of mostly men, 70% male, ages 25 to 55, generally working professionals or college age, which is very different than a bricks and mortar practice, which is predominantly female and also predominantly insurance-based. I don't take any insurance in my practice. It's typically a very high-end concierge type practice. And what I have found, regardless of where they are, even in the hospital, is men had this body dysmorphia about them. Not Adonis complex, just something about their body that they felt was inadequate. I thought that's interesting. Why? And why more so now? And more commonly among the men under, say, 35, under 40, even millennials primarily. I thought this is weird. I'm flipping through reading the paper one day, and comes up in the paper that millennial men would like to be able to go to the gym in the locker room and change and use the services, but never be seen naked. I thought, this is interesting. What is this all about? I'm not hallucinating this. This is actually a thing. So, and more I find out that men are very sensitive about their body and that sort of thing. So I did a podcast on insecurities in general, just kind of underlining, explaining, and doing this universality theme that might come out, say, in a group session. Like, look, everyone has insecurities about their body, but here's how you have to get over it, kind of thing. And so it became basically explaining general themes that people might be worried about. Another psychology of it all was, there are a lot of questions about the DNP program, and oh my God, I can't come up with a project, or I don't know how to appraise the literature, or I can't do a conceptual model. Or so then I did a bunch of podcasts on that, one for each topic, essentially demystifying what is considered mystifying. So that's why the title, The Psychology of It All.
Fabulous. What an entrepreneur. What other questions do people have for Dr. Zakhari? Everyone has certainly been enjoying it. There's loads of comments.
I'm just trying to read through
about how good
comments were written here that I missed. CT heads go on. Yeah, watch for 4 hours is a popular one. Some people say wait 4 hours to scan. At least you've had time to catch the bleed. Now they say, well, what's so magical about 4? What if they bled in 5? Those are made up numbers. I looked in the literature to find out what is there a time that we should scan. The only thing the literature said was don't scan unnecessarily, and certainly don't serial scan, which was also a thing at one time where we'd scan them now and again in 4 hours and again in 8 hours. Worked in ED 16 years RNNP. My observation is that most providers in the ER practice what I can call, yes, they do practice defensive medicine. That's exactly right. And essentially what we're trying to do is document in the chart to say, here are the criteria for scanning. We didn't do this. You know, the reason it perpetuates this persistence in scanning is it's going to be really hard in 10 to 15 years to blame the leukemia on the head CAT scan you received, so many years ago. That's truthfully why it perpetuates. It's hard to tie proximate cause into the adverse effect of the scan, but suffice it to say, we should do what's right.
There's another question here. What part does the quality work play in your practice, or are they separate?
No, it's very much related. I'm on the, what do we call it now? The name has changed from Quality Committee to Root Cause Analysis Committee or something. So I have an area where I am board certified in both family practice and psychiatry, and I work as a hospitalist in psychiatry currently. So what I get are the medical complications that arise in psychiatry, like if it's a near miss or something that maybe we caused, or if there's a medical complication that arises in psychiatry, those are the cases I review. And so why that's interesting from a quality perspective is, we should be doing things like, for example, checking EKGs on people that have antipsychotic medication for QT prolongation, right? We should be looking at things that can also prolong beyond antipsychotics, like, for example, dehydration can prolong it, polysubstance abuse can prolong it, withdrawal can prolong it. So what happens is when someone comes in with this whole constellation of things, like we put them on an antipsychotic and they happen to be polysubstance and they're dehydrated and etc., and there's no baseline EKG, and then they suddenly have like a major cardiac event, how did we miss that? So that's the quality work I would look at. Or, for example, did we overshoot the lithium in an elderly person and now they're renally insufficient, things like that. So when that becomes a medical complication in psychiatry, those are the quality things that I generally would review. When I was doing this CAT scan thing, I got every single fall to review, which I hated and want nothing more to do with this project because I'm so fed up with it. But it kind of happens when you go through a DNP program. Your topic is great, but then you get done with it, you never want to see it again.
Very true. It's
true. I mean, if I never see a CAT scan or a fall again, it'll be too soon.
There was another question here. Someone missed your comment. They said about something golden something at the end of the presentation. Could you repeat that? I don't know if you were talking about the miracle question, or I don't remember something golden. Miracle question. Yes, that was there.
Miracle question.
Just
yes, the
miracle
that
question. Quickly again.
Yeah, that's essentially clarifying how will you know if the outcome has been met. So, for example, when someone presents to therapy and they say they come with their child and they say, my kid is not doing well in school and he's starting fights and all of these sorts of things, and so the school has referred us for therapy or something. And so one of the questions you're going to ask is, well, how will you know that this has been a successful outcome? Or how do you know when therapy has been achieved? And you're not asking the person to tell you the answer. What you're trying to figure out from them essentially is, what really is bothersome to you? You know, what is it? So the mom may be fine if I don't get any more calls from the school. Okay, that's fine. But in reality, we need your kid to stop beating up the other kids in the school. That's the real problem. Not that the school not, I mean, we could just tell the school not to call you and that would solve your problem. Yes, because then I don't have to leave work. Oh, interesting. So it's a disruption to your workday that's really the problem, not so much that your kid is beating people up in school. That's equally valid. I mean, she's got to afford the therapy. I'm not working for free. She's got to pay the bills. So, you know, I get it. So listen, kid, here's the deal. We're going to have to figure out a way that you can deal with your anger and not beat up the other kids. And so the school doesn't call your mother and we interrupt the workday. You see, so what you're doing is you're trying to figure out where the cultural inertia is. What are the various stakeholders valuing about an intervention for the purpose of quality improvement? Does that answer your question?
Hopefully. Someone here asked, could you name any psych mental health nurse practitioners with innovative or entrepreneurial endeavors that you'd like to follow for information or inspiration?
Oh, name any for endeavors.
Anyone's others that have.
Who do I follow? I guess you're asking, who do I follow, or?
Yes.
Oh, yeah. Well, when I first started my practice, there's a woman, she was out of the Pacific Northwest, now she's out of the Midwest. Her name was Barbara Phillips. She started a nurse practitioner business owners blog and website. That was a great spot to figure out what one needed to do to start a business, build a practice, etc. She was very handy. Mimi Secors is quite popular. She's also launched, but I met her in a Barbara Phillips group on social media. There's some personalities out there. There's a woman who has Beacon Continuing Ed. I've done some work with her. I developed a psychopharmacology 2-hour online course that grants 2 pharm credits like CE. So I've worked with her, and she developed her continuing ed business out of travel health. That's Beacon CE. What's her name? Nancy Drabino. She's another one. There are a few. There's actually a few. There's like a group out there that once you get into like business ownership, which I highly recommend, think about entrepreneurial endeavors for yourselves. It really gives you a whole new perspective on the delivery of healthcare. I would love nurses to realize that profit is not a bad word. Doing something for a profit incentive can actually be a really good thing, because in order to turn that profit, you're going to have to provide a service that is valuable to the community. So profit is not a bad word, and try to follow the money and be somewhat in tune to it, because at the end of the day, it's why we work. We have to work.
Very true. Very true. Did you see that last comment there? How do you meet the requirements for recertification in your 3 areas if you only practice as a psych nurse practitioner?
I do not. I practice both as I practice as a family and psych nurse practitioner. So in my private practice, I do both psychiatric and family practice house calls. And in the hospital, I do family practice as a hospitalist. So that's how I'm able to combine the 2. Is that do we answer? I'm FNP, Psych NP. How do you meet the requirements in your 3 areas? Well, I also do a lot of CE. I constantly have to do CE. I try to find ways to triple dip the CE. And what do I mean by that? Well, so if I write the article, I get CE for that. If I turn the article into a presentation and deliver it, the same article, there's a way to get CE for that. And then if I attend my own CE course online and pay the money, I can get CE for that. You kind of have to work it. I also try to look for conferences that will triple dip for me. And what I mean by that is, so if I go to a women's health topic, women's health gives me credit for my sex education. It gives me credit for family practice. And if there's any sort of mental anything women's health, that covers some psych credits as well. So you try to get really creative with the courses that you take and the articles you read. And as it's almost a double-edged, it's a curse, it's a blessing and a curse to be triple board certified and trained in, I'm also trained in sex therapy and forensics. The curse is that you're forever having to make sure you're meeting enough CE requirements. So what you do is you try to find things that cover across multiple specialties. I've not had a problem maintaining that now for the last, how long? Probably 6 years or so. Women's health providing mental health credits, it can, not automatically. So for example, if you do something with, say, postpartum depression, there's women's health and mental health there. If you do something with like anxiety and fertility, that covers sex therapy and mental health and women's health. And you do something with like something with parenting, that covers both. My involvement with forensics is I was trained as a sexual assault forensic examiner. I did that after I became family practice and psychiatry certified. And I figured that was a really good place to combine the two, because you're being called in to do both, the forensic investigation, gathering evidence, interviewing, there's a lot of psych skills there, and then the actual women's health or, men's health, you're doing the exam and that sort of thing. So that combines both.
There's another question here from Aisha. My DNP-QI project is to improve perinatal depression screening at their practice. We're a large FQHC in New York City, and I've noticed that there is a significant lack of screening of depression in women we serve. Mm-hmm. How often do you see perinatal depression being referred to you?
Well, I get it in the hospital. So I get them when they are depressed with psychotic symptoms, or they've deliberately gone off their mood stabilizers in the anticipation of getting pregnant. So we do see that here. I will tell you the reason you're finding reduced screening is because people do not want to be stuck with, what do I do with this information? There is an element in psychiatry and in medicine in general, you don't ask a question you don't want the answer to. It's almost considered to be a little, and there's an ethical debate. Is it fair to ask somebody to screen them for a problem and you have no proposed solution for it? Think of that almost like doing genetic testing for something like Huntington's. Do you screen them for Huntington's knowing that this is a guaranteed disease they're going to get and there will be decline and there's no treatment? Some would say it's better not to know. Others would say it's better to know, at least I can prepare. That depends. So screening is not the holy grail, and neither is education, because you may open a Pandora's box and cause unnecessary angst. So I do think it's important, but I don't have a really good answer if there's a lack of services. And at the end of the day, what you can do is then focus on function. How are you functioning? I mean, you could be depressed, you could be schizophrenic, you could be bipolar, but you could remain functioning. I see someone wrote California requiring screening now. That's great. And then what are you going to do when you find the positive results? You're going to have someone to refer them to. So you may refer them to a waiting list.
Yeah, we had started a perinatal mood disorder clinic in our OBGYN clinic in Detroit. And within 3 months, we were so overwhelmed with referrals that there was a 3-month waiting list.
Right.
And so we did it is because the psych mental health people were so far booked out.
Right. That happens. And so, it's funny, there was a case in Canada, and I will tell you, this was a while back when Canada had the rule that you could not offer, Canada kind of has a tiered system. Yeah, they have universal health care, but they also kind of have a private pay system. And they had a rule at one time that said, the private pay system could not offer services that were available on the public option. And so what happened was a case went forth for a guy who had a hip issue. He said, I want it replaced. I want to do it privately. And the surgeon wasn't allowed to do it privately because it was a service that was covered. He just had to wait for the public option to be serviced. This went all the way through the Supreme Court of Canada, and they basically ruled that access to a waiting list was not the same thing as access to care. And so now they can cover some of the same services that are publicly offered in the private sector of Canada's healthcare system. And we have a little bit of a similar problem here. Just because you screen and find and you refer, who's going to see them? And now you've got everyone around them worried. So And there may not be a social person that can step in and help bridge.
Yeah, it's a big problem.
Yeah.
Well, this has been an absolutely fabulous discussion. I greatly appreciate it, and I know all of the people who participated did. Is there any final comments that you have for us?
I'm performing ultrasound. Let's see, Regina. I'm reading through these comments just to make sure we catch everything. I'm sorry, what was your question again?
I was just thanking you.
Oh.
And asking you if you have any final statement you'd like to let everyone leave with.
Yes, my final statement for everybody is please be in a perpetual state of dissatisfaction with the status quo. Please don't become complacent. Please never stop learning, because your dissatisfaction will help you drive change and make you develop a meaningful career rather than becoming a cog in the wheel. Most people go to graduate school because they're looking for more options. They want to do something better. They want to do it on their own terms. Great, do that. But the only way to do that and to do that well is to ask yourself, is to be dissatisfied with the status quo. My mind is always going on the fact there ought to be a better way. This can't possibly be the best there is. And then that drives you to figuring out an innovative way to contend with it. So my recommendation is to forever be dissatisfied.
Actually, that's fabulous, because that's kind of feeds right into the quality improvement projects that our students are doing, is always questioning and looking for improvements. So thank you again on behalf of the faculty and Frontier Nursing University. We greatly appreciate the time you've given to us. It was such a great gift. And I'll say good night, and everyone.
My pleasure. I hope to see you all in New Orleans if you're going to be there at the AANP in 2020 in New Orleans. So hopefully you'll be there.
Great.
Take care.
Good night. Thank you.